Welcome everyone. That's a very good news today. We are in module 2 of our GN fellowships, and we are almost halfway in our 1-year online clinical glomerulonephritis fellowship program. And as you know, today is our 5th webinar that we are conducting every month. And today we have a great guest speaker, Dr. Bianca Davidson from University of Cape Town, South Africa. She's going to give us the up-to-date information about the updated KDIGO 2024 ANCA vasculitis guidelines that was published a couple months ago. And we also going to have a nice case presentation by Dr. Shuru Nagar, a challenging case of obstetric nephrology. This will be followed by a literature review from Dr. Rasha Samir. Then we'll have Dr. Nikki Wern moderating the discussion. Just a few announcements here. We are starting a critical care nephrology fellowship starting in May 20, so 20 days from now. It's structured as 3 modules, 16 weeks each, 96 credit hour. It's accredited by the American Association of Continuing Medical Education. And the deadline for application is actually today. So this is the last poll. So if you are interested, or if you have a colleague or a friend who is interested, you can get for yourself or for your colleagues 15% discount. This is valid for all World Kidney Academy fellows. So if you are a fellow in our GN program or transplant program, or any of the other program, you can get 15% discount for yourself or for your colleagues or friends. So again, we are finishing the mini module 2 of the fellowship. And here is our module 1, because also we have a new batch who just started a couple months ago with the fellowship. So they are also finishing the second mini module, but of module 1. But the majority of you are finishing the second mini module of module 2. So they are, studying the onconephrology, and next week they will have amyloidosis, then MPGN, then C3 glomerulopathy and the cryo. Then the last module, the third module, is shorter module because we are going to focus more on final tasks and assignments. And the focus of the third module will be the hereditary nephritis, the post-transplant GN, the TME. Then we are going to wrap up with the main lessons and take-home points, including traditional and non-traditional, conservative and immunosuppressive approaches, role of plasma exchange in GN, and novel and pipeline therapeutics. So next module is supposed to start July 1st, so just 2 months from now. And we have our next webinar on May 30. So please share with us any of your interesting cases, if you want to do a literature review or mini didactics, just let us know. And the graduation day for the first batch for the majority of you will be October 7th, 2024. So congrats. It has been a long pathway that you have been involving on. And this is a very successful fellowship. We are learning all together, not only the fellows, but also the tutors. And by the end of this fellowship, you will receive the American Association of Continuing Medical Education certificates, and you will be graduated to a mentor and a trainer level. So I like this quote from Benjamin Franklin: "Tell me, and I will forget; teach me, and I may remember; involve me, and I learn." And what we have, decided here in this fellowship program is to involve all of our fellows, not to receive one-way education, but bi-directional with tasks and assignments and feedback. So I think this is the way to learn better. And of course, the best way to retain this information is to practice, is to apply this knowledge into your daily practice. You are very special to us, so don't ever forget what we are educating and teaching you. And I'm going to stop by here and will let Professor Nikki Wern to introduce our first speaker, Dr. Bianca Davidson.
Thank you very much, Prof. El-Husseini, and thank you very much for initiating and integrating this really wonderful program. I'm actually very proud to be part of it. I'm going to introduce this evening Dr. Bianca Davidson, who I'm very lucky to have in my department. She has a very keen interest on glomerular disease, runs the Glomerulonephritis Clinic at Pre-eclampsia Hospital in Cape Town, has been very responsible for many protocols in our unit, and really is very up to date with the literature. She's also a very keen member of the International Society of Nephrology and is the incoming chair for the Young Nephrologists. So some of you may know her in that capacity. So with that introduction, I want to thank Bianca for her contribution this evening, and please keep your questions. I'm happy to try and moderate the questions, have discussions around anyone's concerns. So I hope you enjoy the presentation. Take it from here. Thanks, Bianca.
Great, thank you very much. I'm just going to share my screen. Okay, so let me just quickly move this so I can get the talk. All right, so I was asked to do an update on what the new guidelines say, and I thought this was a great addition to the ANCA vasculitis talk that you had already. And it's always nice to get given a topic where there hasn't been a lot of change, because I was given about 10 minutes, and I thought instead of telling you there've been very few changes, I thought we could have a look as to why some of those changes have happened. So everybody knows about ANCA vasculitis. We've all seen patients that have had ANCA vasculitis. They are ill. They are in ICU, and I think it's really important that we have a firm grasp on their management. These slides are just going on their own. I'm going to try and keep up with them. All right, so the first clinical practice guidelines were released by KDIGO in 2021, and there was a section on ANCA vasculitis in this. There was a revision of this that was done in 2024. And we always have to ask ourselves what has prompted these revision of the guidelines. The most significant revisions were due to the approval of C5A, otherwise known as avacopan, by the FDA and the European Medicine Agency, and it's now an add-on to standard of care. The second biggest change is now a larger emphasis on reduced dosing of glucocorticoids, largely because of the low-VAS trial. So the structure of this talk, I want to go through each of the sections, and we're going to point out where there are changes, and where there are, we will discuss them. We are also, if there are no changes, we're just going to go through and have a brief reminder. So firstly, just to remind you about diagnosis. If you have a clinical presentation of small vessel vasculitis with positive serology, you shouldn't wait for the kidney biopsy result before starting treatment. ANCA vasculitis should always be done in a center which has expertise, And the persistence of ANCA positivity, an increase in ANCA levels, or a change from ANCA from negative to positive is a predictor of future relapse and can help us in our treatment decision making. So what have been the major changes? And these largely surround the treatment section. So when you have a look here, that the recommendation 9.3.1.1 is still the same. People with ANCA vasculitis are going to be treated with glucocorticoids, either with rituximab or with cyclophosphamide. But what you can see here is that they have added in avacopan as one of the options, which can be used in place of glucocorticoids. There's also a stronger recommendation to wean steroids quicker and use lower doses of the glucocorticoids. The practice point 9.3.1.2, which looks at a subset of patients with severe ANCA glomerulonephritis. So these have serum creatinines of more than 4 or 354 micromoles. The recommendation for this hasn't changed. There's limited current data on the use of rituximab in patients with severe. I'm sorry, my slides are just going ahead with themselves. So there's limited data to support the use of rituximab currently. So the KDIGO guidelines still advocate for the use of cyclophosphamide in the subgroup with very severe ANCA vasculitis. They also have advocated for the use of a combination of rituximab and cyclophosphamide together within this setting. The decision between using rituximab and cyclophosphamide hasn't changed, and they've left us with a table that we can use our clinical discretion and largely resource availability to make this choice. So what is avacopan, and how did they come to the conclusion that we should be using it? So this is largely based in the guidelines now because it is FDA approved. But to take a step back, there are two major trials that have been done that have shown that avacopan does have a place in the treatment of ANCA vasculitis. The first one is the Advocate trial, which the panel or working group felt that there were no serious methodological concerns. And the Classic trial, which they had a concern about the high dropout rate and the change in the a priori primary outcomes, but their decision was to include both of the trials and to make it a practice point rather than a recommendation. So the Advocate trial took 331 patients that were either induced with cyclophosphamide or with rituximab, and they randomized them to either avacopan or to prednisone. This was a trial to see whether avacopan was non-inferior to prednisone, and what they looked at was clinical remission at 26 weeks and sustained remission at 26 weeks and 52 weeks. And what you can see here is that avacopan showed that it was non-inferior to prednisone. There were two subsequent sub-studies or post hoc analysis that were done from the Advocate trial. The first one was to look at the toxicity of glucocorticoids. I thought this was a very interesting analysis for two reasons. When you look at glucocorticoid toxicity, we usually think about BMI, glucose intolerance, lipid metabolism, and skin toxicity. But they use different scoring systems to assess how much glucocorticoid toxicity the patients had. It was unsurprising on this post hoc analysis that the group that had avacopan had a lower overall prednisone dosing, so it was 1 gram versus 3, and they had a significant less glucocorticoid toxicity than the steroid group, and that was based on the CWS and the AIS score. What they had said is that avacopan should be considered to replace prednisone in those that were at risk of glucocorticoid toxicity. And in the report, they actually mentioned how nuanced glucocorticoid toxicity is, as they mentioned that a lot of patients would improve on certain aspects of their glucocorticoid toxicity, but not on others, with reducing the dose of the corticosteroids. The second post hoc analysis looked at patients with lower eGFR. So what was found was that avacopan is a better agent in this post hoc analysis, bearing in mind that there were only 27 patients in both groups that had an eGFR of less than 20. But what they found was that there was a statistical significance change in eGFR. Once again, I apologize, these slides are just going. And there was an increase by twofold in the eGFR, which was statistically significant. So just a reminder on the mechanism of action of avacopan. It's a C5a inhibitor, and as you learned in the pathogenesis of ANCA vasculitis, C5a plays a pivotal role in an autoactivation loop. So avacopan, as it blocks C5a, it cuts back on that autoactivation of the complement and dampens down all of the inflammation. And really the place that it has and the role that it plays in ANCA vasculitis now is to rather use it instead of steroids in patients that are at risk of glucocorticoid toxicity, or to use it in patients that have a lower eGFR. We don't have access to it. It's too expensive for us here in South Africa, and I'm not sure if everybody on the call has used it or has access to it. So I thought I would put it in the table just to remind ourselves that the dosing of it is 30 milligrams twice a day. The second point that was raised in the newer guidelines was a stronger emphasis on lower dose steroids. The decision for this was based on two studies. The first one was PlexiVas, and the second one was the low-VAS trial. So I've attached the dosing schedule of prednisone of the PlexiVas trial, and what you can see is that by the second week, patients were on 0.5 milligrams per kilogram, and generally by the end of the year, they were on 5 milligrams. The low-VAS trial randomized patients to 0.5 milligrams per kilogram in the low-dose arm, and in the high-dose arm, they were at 1 milligram. All of the patients received rituximab, and the reduced dosage group led to similar remission rates with less severe infections. One of the major limitations of the low-VAS trial was that it was mainly a Japanese cohort and mostly had MPO ANCA vasculitis. Nevertheless, the working group said that due to the fact that both the PlexiVas and the low-VAS trial showed an improved safety profile and similar relapse rates, it's now advocated to use lower dose glucocorticoids in ANCA vasculitis. So this is the low-VAS trial, and what you can see here is that there's a low-dose arm and a high-dose arm, and by 24 weeks, on the low-dose arm, you were on no prednisone at all, and the high-dose arm, you were still on 10 milligrams. When you're looking at the outcomes of this trial, the graph A, this is a Kaplan-Meier showing the composite endpoint, which was the need for ongoing dialysis, death, and the time interval before the first severe adverse event. And what you can see here is that the reduced dose prednisone had better outcomes. There were similar survival rates, and there was very similar rates of relapse, and that was why the committee felt that it was worth patients being on a lower corticosteroid dosage. Moving on to plasma exchange, there is no change to the recommendation here. KDIGO still feels that in patients that have severe ANCA glomerulonephritis with a creatinine of more than 3.4, that there is a role for plasma exchange, especially if it's in the setting of diffuse alveolar hemorrhage and hypoxemia. And the second caveat is that it must be used in patients with overlap syndrome with ANCA and anti-GBM. There's not a lot of consensus with this. So I put the slide in the initial lecture, but the large societies or governing bodies, EULA, KDIGO, and the American College of Rheumatology do not have consensus over this point. KDIGO is really the only one that states that PLEX should be considered. And the reason for this is that there is evidence that from a meta-analysis that there's a reduction of kidney failure at 12 months with patients that have plasma exchange, and that this comes at the cost of an increased risk of serious infection. When they did a public public review and polled whether the public was happy with this consensus, it was relatively low. So 75% of people thought that plasma exchange should not be used. So currently, plasma exchange is not routinely used in patients with an EGFR of less than 50. It should be considered in the setting of severe renal failure. It definitely should be considered if there is ANCA and anti-GBM together, and plasma exchange should not be considered if there's alveolar hemorrhage without hypoxemia. In terms of maintenance treatment, there's not a lot that has changed. You can still consider using a rituximab or azathioprine. They have mentioned a more definitive timeline on when you should think about weaning off, and they have given a recommendation on dosing schedules of rituximab. So they have said that the optimal duration of therapy is 18 months to 4 years, and they've still left it at our discretion as to what factors we will use to decide how long to treat someone with ANCA vasculitis for. And they have said that with maintenance dosage, rituximab can be given at fixed schedule or upon the reappearance of CD19. They have said that if you wait for the B cell counts and you are led by that, there are fewer infusions and lower cost, which becomes really important when you work in resource limited settings like ours. I like the fact that I get to look at the patient and decide on an individual basis how long to give the maintenance therapy for. It gives you a much better discussion point to have with the patient to say you have X amount of risk factors for relapse, and that's why we should be going for longer. So I highly recommend that you look at this table. That hasn't changed. It was in the initial guidelines as well. There is no new evidence that has come up about relapsing refractory disease. So the practice points haven't changed. Those that have relapsing disease should be induced preferably with rituximab. Refractory disease should be treated with an increased dose of glucocorticoids. If you initially used rituximab, you should try with cyclophosphamide instead, and plasma exchange should be considered. And then there is no change to the recommendation of transplantation either. You should wait for 6 months before you, with someone in a complete clinical remission, before you decide to transplant them. I hope that gives you a bit of context as to the changes that have been made and reassures you that there isn't a lot of changes that have been made from the 2021 guidelines. And I'm happy to deal with questions after this. Thank you for the time.
Thanks very much, Bianca. There were quite a few questions, actually. We've got about just over 5 minutes, so we'll just try to keep them very directed. And some of the questions I might need some assistance with because I'm not quite sure of what the slant that the person is trying to get. So let's go from the top. The first question is avacopan. Do you use it in both in C-ANCA and P-ANCA? And do you do the ANCA titers in MPO and PR3? And there is a question in the chat about, and I don't know the answer to this, but IL-4 and 5 in eosinophilic GN. So let's tackle the first one. Avacopan is used in both PR3 and MPO.
So the guidelines do not differentiate as to which subtype, PR3 or MPO, whether avacopan should be used. It is a general guideline about both. So and the trials included both MPO and PR3. So what this is telling us is that, and we know that PR3 ANCA vasculitis is much more predisposed to relapse than MPO. They did include both of them, so I think it is safe to say that you can use it in both. As far as
I'm going to the titers move on. I'm just going to move it through just so we can get as many questions as possible. As far as titers go.
So I went to this very interesting talk at the World Conference recently, and that was done by a specialist that works in Europe that only does ANCA vasculitis, and they are focusing more and more on the role of ANCAs ANCA titers in looking at your predisposition for relapse. So on my first slide, I did mention that the recommendations say the role of ANCA titers, you should be doing them at the end of your induction treatment. And what you're hoping for is that your ANCA titers go from positive to negative. If they are still positive, or if they are increasing, if they change from negative to positive, it is a warning sign that there is an increased risk of you relapsing, and it will give you a guide as to who you would want to possibly treat with maintenance treatment for longer, and who you would want to follow up closer. So I hope that answers the question. I know when we were senior reggers and taught about ANCA vasculitis, ANCA serology was mainly used in terms of diagnosis, but it definitely is showing that it has got a greater role for monitoring and risk of relapse within the future.
Excellent. And your understanding of IL-4 and 5? I'm assuming that EPGA is actually eosinophilic.
Yeah, I must be honest, it wasn't covered in this guideline now, and there was no talk about targeted treatments against it in this current guideline. So I'm sure it's coming. I mean, a lot of the biologics are now targeting different chemokines and cytokines in different points along the immune response, but I don't have an answer for that directly now with these guidelines.
Okay, we will watch that space. So the next question is cyclophosphamide and vasculitis. Do you give the same dose as per the Euro lupus protocol, or is it different?
So it is slightly different, and I would recommend that when you are giving it, if you're working in a center that isn't familiar with it, that you follow the KDIGO guidelines. They give I did put the slide in there, and the dosing schedule is quite clearly laid out within the KDIGO guidelines as to the dosage that should be given, and the intervals that it's given as. So I think I'm going to refer that question back to the guidelines, because it gives quite a clear guide schedule, and it is slightly different to the Euro lupus guidelines.
Okay. The next question is the treatment duration in vasculitis, and to check IgG with rituximab. I think this is quite a few parts of this question, and when to replace IVIG or replace with IVIG.
Okay, so just start with the first part of that question again.
Yep, treatment, I'll break it down actually. The treatment duration in vasculitis.
So there was one slide that we covered a little bit later in the talk, that KDIGO hasn't put their head on a block and said that you need to treat for 18 months or for 4 years. They have left it up to your clinical guidelines. So they've left quite a clear table in there, and we use it often in our clinical practice. So if you are if you have a PR3 positive, if you have GPA, if you have nose, throat, and ear involvement, if your creatinine was very high to begin with, your chances of relapse are much higher, and then you would clinically decide to go for longer. So you need to apply the clinical context of the patient at the moment, and then the duration of the maintenance treatment that you end up giving. So I hope that answers your question, and there's not a one-size-fits-all answer. I know in our setting where we have limited dialysis, we err on the side of caution and will probably overtreat patients and treat them for slightly longer than what is needed. But at the same time, it's such a destructive disease that you don't want to stop immunosuppression early. So my recommendation to you is, if you work in a center, to apply your clinical judgment together with the guidelines, and it's anywhere between 18 months and 4 years. So if your clinical picture is that of a low chance of relapse, you can end the treatment at 18 months, provided you discuss with the patient the risk versus benefit. If you are in a center that is resource limited, doesn't have access to dialysis, and especially if your patients have got high risks of developing a relapse, we would recommend that you treat for longer, and that is up to 4 years. So we don't have the luxury of treating with rituximab as maintenance due to being in a resource limited setting. So your question about chronic management with rituximab and monitoring IVIG and timing of that, I must be honest, I'm happy to contact somebody that does work in that center that is able to do that, and I can relay the answer back to you, but we don't have exposure to that. Just to let you know, rituximab in our setting is 60,000 Rand versus azathioprine, that's 2 Rand. So it really and azathioprine is still a very effective drug. So I can get back to you with that answer, and I think it is really important because a lot of the guidelines did state that that low immunoglobulin and needing to give IVIG to supplement it is a complication of chronic rituximab use.
Okay, Bianca, I think we've got time probably for 1 or 2 quick questions. So I'm going to move on to avacopan. Should it go without steroids, even in clinically severe cases?
So all of the studies that were done gave Medrol Pulse, cyclophosphamide, gave a week's worth of the first week of glucocorticoid, and then the patients were randomized to avacopan without glucose, so without glucocorticoids. So they obviously had a very rapid wean of their steroids. And the average dose of glucocorticoids that patients who got avacopan was round about a gram. And if you think about that between the methylprednisone, that's not a high dose of steroids. So they were very rapidly weaned off that off their glucocorticoids, and then were put onto avacopan BD. And I think there is enough evidence now in very well-structured RCTs that show that it is non-inferior. So it can be used to replace glucocorticoids. And it had similar remission rates at 26 weeks, and at that stretched out to a sustained remission at 52 weeks. So I think that it can be confidently used.
Just the last question, I think, Prof, if one last question, how long to continue avacopan, sorry.
So it was only continued for 6 months.
I'm very conscious of the time, so are we happy to continue with the presentations? It's been wonderful having all the communication. I think what we could attempt to do is keep the questions, and we can, and Bianca, perhaps you wouldn't mind replying to the rest of the.
Sure. I'm just seeing a very interesting question here about how to treat ANCA flare in pregnancy, and I'm very glad that Russia is on the call because she's quite experienced with pregnancy, but I'm just going to say with great difficulty, because cyclophosphamide has only been used with in cases of patients who are pregnant, and there's not a lot of data on the long-term effects. Rituximab, though, has been used in pregnancy. It is linked to reduced cell counts within the fetus. So if you were to ask me which one I would prefer personally, and I don't think that there is a right or wrong answer, it's probably safer to use rituximab, but I would be interested to hear what Russia thinks.
Excellent. I think I'm going to finish it there, just because I would like to stick to the schedule this evening. So I'm going to hand it back to Prof. El-Husseini to introduce the next speaker.
Very nice. Thank you so much, Professor Nikki, for moderating the discussion. Thank you so much, Professor Barika Davidson, for this amazing presentation. It's a tough job, but you make it very easy to us. So thank you so much for that. I just have, two quick follow-up questions. First, given the cost of avacopan, and hopefully it will be cheaper in the future, but for 2024, do you have any preference? What subgroup of patient would benefit more, or what kind of patient would you consider it, giving the cost, and also it's FDA approved on top of steroids and the standard induction therapy, so it's not FDA approved yet as a replacement. It could help in steroid minimization, but it's not a steroid sparing or avoidance until now. Maybe in the future, future study can help us what will happen if we just avoid completely steroid. But tell us, because of the cost and the benefit, which group of patient would you consider it more?
I think that that's an excellent question. So even in a cost-constrained environment, if there's a better drug and you have a good rationalization, you can always motivate for it. And definitely there's a role for avacopan in patients that have a high if they're overweight, if they have a high family risk of diabetes, if they're elderly and are diabetic already. I think those risk factors for glucocorticoid toxicity is then very, very high, and that is the subgroup of patients that would probably benefit from it. So I hope that that answers your question.
Very good, very good. Thank you so much. My last question, also quick question. I was wondering why calcineurin inhibitors are not mentioned at any recommendation or suggestion in the KDIGO. Is it because it was already compared in ANCA-associated vasculitis to the standard therapy and it showed negative results, or it wasn't compared to the standard of care? Where is the calcineurin inhibitor in ANCA-associated vasculitis? We use it in lupus, we use it in primary and secondary, GN. So why it's not in vasculitis?
Yeah, it's a very interesting question. And the one part about it that makes me wonder is that it is quite a complement and B cell antibody mediated problem. And I just wonder if calcineurin inhibitors would be the most effective in that role. So I don't know the answer off the top of my head to that. I didn't come across them at all in the 2021 or the 2024 guidelines. But rituximab makes sense. You're going to the place where antibodies are produced, so it's an effective treatment. Avacopan makes sense. You're blocking the autoactivation of the C5A and the complement loop, which is now being seen as one of the major drivers of it. So those two treatments make pathological or pathognomonic sense to me. And cyclophosphamide really is like, I mean, it's like just taking a massive wipeout to most of your immune system. So you know it's going to work in most of those settings. But I do think it is a really interesting point and a good question. It probably just has to do with its role in the pathogenesis and how, in which part of the immune system it ends up blocking. That would be my assumption to that.
Thank you so much. That's very nice. I think we got more questions, but for the sake of the time, I think we need to proceed. And our next speaker is Dr. Shuru Nagar. She's a lecturer of nephrology at Mansoura University, and she's the module lead of the GN program. She's doing fantastic job in moderating and reviewing the whole material, proofreading all the scientific material to make sure that they are all correct. There is no typos and they are up to date. So without further ado, I will let her share her screen and present her case. It's a very interesting case of pregnancy and associated with pre-eclampsia and other complication in CKD patients with proteinuria. Then Dr. Rasha Samir is going to do a literature review after Dr. Shuru's presentation.
Hello, everyone. Is my voice clear?
Yes. Very good.
Okay. My presentation today is entitled A Wish of Lifetime, talking about a challenging case of a pregnant lady with chronic kidney disease. A 28-year-old female patient with history of hypertension 9 years ago, maintained on candesartan, hydrochlorothiazide, eplerenone, and nebivolol. 3 years ago, the patient was diagnosed to have chronic kidney disease. Her last BESA serum creatinine was 1.3. The patient was gravida 4, bara 0. In the past 6 years, the patient had 4 unsuccessful pregnancies thought to be due to pre-eclamptic toxemia, leading to recurrent stillbirths between 24 to 28 weeks of gestation. The patient presented to our Mansoura Obstetric Nephrology Clinic seeking another pregnancy trial. So before pregnancy, clinical examination of the patient was normal, apart from elevated blood pressure, 140/90 millimeter mercury, and barely recognized goiter by neck examination. Laboratory investigation revealed increased serum creatinine 1.3 and 24-hour urinary protein of 800 milligrams. Immune profile was negative except for lupus anticoagulant IgM antibodies, which were positive on 2 different occasions. As the patient had recurrent stillbirths with the positive lupus anticoagulant antibodies, a diagnosis of antiphospholipid syndrome was established. Thyroid profile was ordered, TSH was low, and total T3 and T4 were elevated, while neck ultrasound showed multinodular goiter. So to summarize, my patient is gravida 4, Brazil, with history of hypertension and chronic kidney disease. Her basal serum creatinine was 1.3, 24-hour unit protein 800 milligram, with recent diagnosis of antiphospholipid syndrome and hyperthyroidism. Antenatal management of this patient included counseling, optimizing thyroid function, controlling blood pressure, and the identification of original kidney disease. The patient was counseled regarding renal outcomes and fetal outcomes according to maternal pre-pregnancy serum creatinine. To optimize thyroid function, the patient was referred to endocrinology unit, where the diagnosis of primary hyperthyroidism was established. Antithyroglobulin, TSH receptor, and antithyroid antiperoxidase antibodies all were negative. The patient was started carbimazole and propranolol. After 2 months, unexpectedly, her follow-up thyroid profile revealed severe hypothyroidism. So the patient stopped carbimazole with normalization of thyroid function after 1 month without treatment. As the patient was prepared for pregnancy, antihypertensives were adjusted to safe drugs, including labetalol and alpha-methyl-dopa, with up-titration of doses till proper control of blood pressure. Regarding identification of the original kidney disease, would you support performing renal biopsy to this patient? Renal biopsy in pregnant patient with chronic kidney disease actually is a challenging dilemma. As during pregnancy, there's an increase in renal blood flow with difficulty in bone position at later gestations, which may imply increase in bleeding risk. Therefore, clinical practice guidelines recommend renal biopsy only if histological diagnosis will change the management, and it should be performed in first and early second trimester. On the other hand, renal biopsy before pregnancy can help to establish the diagnosis, decide ideal conception time, and predict the outcome. Therefore, renal biopsy was performed, revealing 14 glomeruli, 3 totally sclerotic and 2 segmentally sclerotic. No glomerular hypercellularity, no thickening in glomerular basement membrane. So, a diagnosis of high large-focal segmental glomerulosclerosis was confirmed by renal biopsy. After antenatal counseling, optimizing thyroid function, controlling blood pressure, and the identification of original kidney disease, now the patient is ready for conception. During pregnancy, low-dose aspirin was started for prophylaxis of pre-eclamptic toxemia. Also, low molecular weight heparin was given to prevent adverse fetal outcomes secondary to antiphospholipid syndrome. Thyroid profile was monitored and was normal, with monthly monitoring of fetal growth parameters. This chart shows maternal clinical course during pregnancy. At first trimester, blood pressure was controlled with alpha-methyl-dopa and labetalol. 24-hour unit protein was 200 milligrams per day, serum creatinine was 1.1. However, at 5th month, blood pressure increased to 160/90. Serum creatinine was 1.2 milligrams per deciliter and proteinuria was 2 grams per day. Antihypertensive doses were adjusted and nifedipine was added. And my question, would you support prescribing immune suppression to the patient at this current situation? So what we didn't prescribe the patient immune suppression, as the original kidney disease showed by renal biopsy was hilar secondary FSGS. And also we considered the exacerbation in hypertension and proteinuria as superimposed pre-eclampsia in this patient. We also did not prescribe diuretic to the patient to avoid any compromise in fetal circulation. So after adjustment of antihypertensive, blood pressure was temporarily controlled. However, at the 8th month, blood pressure markedly increased, reaching up to 200 over 110 millimeter mercury. Despite maximum doses of antihypertensive, proteinuria increased to 3 grams per day. Serum creatinine was 1.2 milligram per deciliter. So at this critical situation, the only solution we had to save maternal and fetal life was termination of pregnancy. So after delivery, our mother delivered a premature baby girl weighing 1.5 kilograms with 2 cardiac septal defects, who was admitted in neonatal ICU for 1.5 months. On the other hand, the mother's blood pressure was controlled, while her postpartum serum creatinine increased from her basal, which was 1.3 to 2.2 milligram per deciliter. So why did this happen? Suggested risk factors for our neonatal cardiac septal defects include prematurity and uncontrolled hypertension. On the other hand, there is no evidence linking between chronic kidney disease and neonatal congenital anomalies. Also, thyroid profile of this patient was normal during the course of pregnancy, and the use of the drug during the whole pregnancy was proven safe. So, to give some hope, the mother's serum creatinine decreased from 2.2 to 1.7 3 months postpartum, and she's maintained on captopril and nifedipine with controlled blood pressure. And our baby girl with good breastfeeding is gaining more weight, reaching 5.5 kilograms. She has no cardiac manifestations. One of the cardiac septal defects was spontaneously closed, and the other one was diminished in size by 30%. We hope we can put our last picture soon when the other cardiac septal defect will close. And my last question to you, would you support future pregnancy in this patient? Thank you.
Very nice, very nice. Yes, unfortunate lady, and at least she has a baby now, and a lot of unanswered questions. And I think you are giving hard time to Dr. Rasha Samir because these questions are tough to answer. I'm going to introduce to you Professor Rasha Samir, who is a great co-worker, investigator, physician, and educator, instructor, everything. She has a role in Mansoura University as an admin person, and also she has a lot of responsibilities in the AFRAN and in the International Society of Nephrology. She's a frequent flyer. She travels a lot these days and present everywhere. She just came in from Buenos Aires last week when she have met Nikki and Bianica there and a lot of others. So she's going to help us to try to address some of these questions.
Thank you, Dr. Amr, for the introduction, and thanks, Shruq, for your presentation and for choosing this case. Indeed, the case you have presented was thought to have pre-eclampsia during her earlier pregnancies or her first 4 pregnancies. And then she was thought to have FSGS based on the kidney biopsy during the last pregnancy. And eventually the patient is thought to have superimposed pre-eclampsia on top of CKD or on top of her chronic FSGS at the end of pregnancy. So all these took me to prepare a brief summary about pre-eclampsia from the nephrology perspective, hoping it would help to solve some items related to the case. So let me share. Sorry. So are the slides obvious now for everyone?
Yes, looks fantastic.
Okay. So preeclampsia from the nephrologist perspective, or from in the eyes of nephrologists, indeed it was an early story, because preeclampsia was first described by Hippocrates around 400 before Christ, who made the early suggestion that headache accompanied by heaviness and convulsions during pregnancy may be a specific insight associated with an unhealthy pregnancy. After that, in 1839, a French clinician described a difference between the kidney disease that appears late in pregnancy and that which presents before gestation and manifests early in pregnancy. He noticed that the disease appears late in pregnancy, almost recover with rapid improvement in abnormalities suggesting kidney abnormalities. In 1843, Lever reported the presence of albuminuria in women with puerperal convulsions. However, the underlying pathophysiology was not yet understood. And in 1893, Shimmer Forrest gave us a detailed histologic description of preeclampsia, describing cloudy swelling and fatty degeneration of tubular epithelium and occasional hyaline fibrin thrombi in the glomerular tufts. So preeclampsia was noted maybe very early, but not fully understood, and thus remains one of the most obscure chapters in medicine. So throughout my agenda, I'm going to present the top 5 whys preeclampsia should be a nephrologist or seen. Number 1, preeclampsia is a podocytopathy. Now, preeclampsia is thought to be a podocytopathy, and that podocytopathy not only a secondary consequence affecting a patient with endothelial dysfunction, but maybe a primary pathology. So, although it was believed for a long time that the kidney develops, like all vessels, some sort of endothelial damage or endothelial dysfunction, the reported histopathological abnormalities were found to be more complex, and that podocytes play the main role. FGS has been recently found to be the dominant histopathological lesion in preeclampsia, and this so that there is androgenic imbalance with enhanced oxidative stress, endothelial dysfunction, and decrease of the nitric oxide and vascular endothelial growth factor. All of this with podocyte injury will eventually lead to a picture of podocytopathy and FGS, and there have been multiple evidence on this observation. The podocyte number to creatinine ratio measured in the urine of women with preeclampsia compared to non-pregnant controls and uncomplicated pregnancies, it has been revealed that there is an increase in the number of podocyte to creatinine ratio in women with preeclampsia compared to non-pregnant and uncomplicated pregnant women. And not only podocyte, but also podocyte proteins were found in the urine specimen from preeclamptic women. The podocyte is thus thought to be the most vulnerable renal cell in preeclampsia, and that the podocyte injury, the endothelial dysfunction, the androgenic imbalance, all of this will lead to the eventual progression of FGS, which will be the first step in the pathway of end-stage kidney disease. Number 2, the clinical profile of preeclampsia and the kidney disease are overlapping. So the differentiation between preeclampsia and the similarly presenting kidney disease in pregnancy is a diagnostic challenge. Simply, if the patient has hypertension, if they have proteinuria or renal impairment, it will be so challenging to differentiate between preeclampsia and other presenting kidney disease. So in terms of research or in terms of studies, there are some suggestions to differentiate between preeclampsia and preeclampsia superimposed on, to differentiate between, yes, preeclampsia and preeclampsia superimposed on top of chronic kidney disease. So if women with preeclampsia have hypertension, defined as systolic blood pressure more than 140 or diastolic blood pressure more than 90, hypertension in women with CKD is considered to be superimposed if there is exaggeration of the blood pressure with systolic more than 160 and diastolic more than 110. if proteinuria is considered in preeclampsia with urinary protein creatinine ratio more than 0.3 milligram per milligram. So if there is more than 100% increase in the protein level in those women, this may be considered superimposed preeclampsia. If the serum creatinine in women with preeclampsia is considered to be alarming, if it's more than 1.1, so in women with CKD, more than 50% increase in the basal serum creatinine within 7 days may be considered as superimposed preeclampsia. All of these are research or suggestions in terms of studies, and we have for sure the extrarenal manifestations, including the hematologic, liver, neurologic, and complications, which may refer to the pathology or the clinical profile of preeclampsia, and the features referring to placental ischemia as the Doppler and fetal growth restriction. Nowadays, we have newly diagnosed, newly used biomarkers such as the placental growth factor and SFLT1 and SFLT1 to placental growth factor ratio, which is widely used in Europe and many countries in the developed world. These androgenic markers not only used to differentiate between preeclampsia and kidney disease, but can be used to predict preeclampsia in on earlier phases. So having low placental growth factor, I present SFLT to placental growth factor ratio high. Sorry, are the slides clear?
Yes, very clear.
Okay. Just received a message to restart my video. And then assess the placental growth factor. SFLT can predict the occurrence of preeclampsia and can differentiate between preeclampsia and the kidney disease. Number 3, preeclampsia may end with CKD. So it is not only that we cannot differentiate between preeclampsia and CKD. Preeclampsia itself may not recover and may end with chronic kidney disease. This is because in women with preeclampsia, there is underlying endothelial dysfunction, podocyte damage, and comorbidities, all of which will contribute to chronic kidney disease. And in this very interesting study, we can see that women who had preeclampsia had a higher risk of progression to end-stage kidney disease. So in the first graph, the red line refers to women with preeclampsia. The black line refers to those without preeclampsia. And here we can find that the cumulative risk of end-stage kidney disease is higher in women with preeclampsia compared to normal. This risk proportionately increases with more frequent episodes of preeclampsia occurring in subsequent pregnancies. So after 2 pregnancies, here in figure B, the black curve refers to women who had no preeclampsia. The blue figure refers to women who had preeclampsia in the first pregnancy only, but not the second. The purple figure refers to, line refers to women who had preeclampsia in the second, but not the first pregnancy. And the red one refers to women who had preeclampsia in both pregnancies. And has been found that having more or frequent episodes of preeclampsia increases the risk of end-stage kidney disease. This was more evident in women who have more than 2 episodes of preeclampsia after 3 pregnancies. The risk of end disease has not only been linked to preeclampsia as one component of the spectrum of hypertensive disorders of pregnancies, but has also found that having an episode of hypertensive disorder of pregnancy, including gestational hypertension, has been associated with long-term risk of CKD or end-stage kidney disease. Unfortunately, the time scale for postpartum resolution is debated. So at the time, we think that most women with preeclampsia completely recover and that proteinuria and hypertension normalize within 3 to 6 months after termination of pregnancy. Still, we find that some histological changes in the kidney may be evident at 18 months postpartum with regression of proteinuria for up to 2 years. So we have a strong evidence that preeclampsia may end with CKD. Number 4, on the other hand, women with CKD are 10 times more likely to develop preeclampsia. So
Those with CKD may have sometimes higher risk to have preeclampsia. This is also because that women with CKD have some sort of endothelial disease, immune and metabolic factors, including complement pathway dysregulation, cytokine regulation, in addition to the comorbidities. All these make those women at increased risk of preeclampsia, and that has been revealed that preeclampsia affects up to 40% of pregnancies in women with CKD. Number 5, CKD after preeclampsia is not only a maternal risk, but there is as well a fetal risk. There is as well a neonatal risk. So preeclampsia increases the risk of preterm delivery and the prematurity simply because when the preeclampsia is diagnosed, there is tendency for premature termination of pregnancy. So having a preterm or having a premature delivery, this will result in having a baby with a low nephron mass. So look at this figure. Here we can find that the majority of nephrons are formed in the 3rd trimester. And the majority of nephrons, or the nephrogenesis process, is almost completed between 32 and 37 weeks gestation, which means that having an infant born before 32 to 37 or before 37 weeks will have incomplete nephrogenesis and will have low nephron mass. And this low nephron mass will contribute to increased risk of CKD and end-stage kidney disease on the long term. And here is the evidence. The adjusted hazard ratio for CKD in babies who were born as early term, late preterm, or very or extremely preterm, less than 34 weeks compared to full term. There is increased risk of CKD proportionate to the degree of prematurity. So if there is preterm birth plus a small for gestational age baby, this increases the risk by more than 3-fold. And because prematurity increases the risk of childhood obesity after premature birth, this is another factor that accelerates the progression of CKD. So here we can see that the lower curve for the renal survival in obese preterm children or obese preterm infant, they showed the worst renal survival compared to non-obese preterm, compared to obese term, and compared to non-obese FSGS born babies. It seems that is a vicious circle, because having a female baby born prematurely due to preeclampsia affecting her mother, this increases her future risk when she grows up and become a mother to have a preterm delivery, and then have a preterm baby, and then again enhance the risk of having another baby with increased risk of CKD and end-stage kidney disease, and so a vicious circle. A female baby who's born prematurely have on the long term increased the risk to give a preterm delivery, and then again a preterm baby, as we can see. So the risk of those who were born prematurely, female infants, I mean, on the long term, when they become mothers, the risk of having at least one very preterm delivery, or at least one preterm delivery, was significantly higher compared to those females who were not that prematurely born at their very early infancy or childhood. Not only the risk of prematurity or giving a preterm labor, but these women, this female baby who has been born prematurely because of preeclampsia in the mother, have increased risk of gestational diabetes, increased risk of gestational hypertension, which again increases the risk of preeclampsia, and again giving a preterm baby, which will have a future risk. So it is like a vicious circle. So about 100 years ago, preeclampsia, eclampsia, and kidney disease and pregnancy were all thought to be under one umbrella, which is toxemia of pregnancy. However, this was not convincing at all. For nephrologists and obstetricians, it remained the same for many years. And then in 1954, when this study was made and multiple kidney biopsies were taken from pregnant women with preeclampsia, interestingly to say that these biopsies were taken at the 39th weeks, just 2 days before delivery, very, very late in pregnancy, 2 days before delivery. it has been revealed that preeclampsia and eclampsia are a unique, distinctive peculiar lesions, and they are not the same like renal disease in pregnancy and other disorders denoted during pregnancy. They are unique, and preeclampsia is unique. Until the current time, we are suggesting that preeclampsia is a podocytopathy, and yet we don't know the exact pathophysiology. We don't know the exact management of such cases. So it still till this time remains obscure for a lot of reasons. And we hope in the future to progress, have further progress, and can delineate many of the secrets related to this disease. And thank you.
Thank you so much, Dr. Rasha, for this fantastic presentation. And I will let Nikki to moderate the discussion and try to address some of the questions in the chat box.
Excellent. Rasha, that was really a fantastic comprehensive overview. It was really awesome. I'm just going to get the two of you, Dr. Nagar as well, the doctor who did the case presentation, both of you, and we'll start with some of the questions that were generated from the case presentation. I know, Rasha, you actually answered some of the questions, but maybe just to emphasize, to confirm that. So the first question was about plaquenil in antiphospholipid syndrome. I guess the use of plaquenil, what its role is.
Yes, there are many recent literatures suggesting the immune modulatory, antithrombotic, and anti-inflammatory role of hydroxychloroquine in antiphospholipid syndrome, and suggest it may be beneficial. However, I think we still need further evidence, but it can be used in situations like pregnancy where it is proven to be safe, especially if antiphospholipid syndrome is secondary to autoimmune conditions like systemic lupus erythematosus.
Excellent. Okay, the next question also regarding the case presentation was, why was immunofluorescence not done?
Yes, we actually have limited cases with immune fluorescence in our area due to financial and logistical constraints. Yes.
Yeah, I think a lot of us are dealing with resource limitations, so I totally understand that. The next question was, the patient checked for lupus.
Yes, her immune profile,
Yes.
all her immune profile was negative, including ANA and anti-double-strand DNA.
And the BMI of the patient?
What? No, she was
mass.
average weight. Yes, average weight, like 27 kilogram per meter square. Yes.
Okay, and then the next two questions are really shouting out no more pregnancies. So was that the recommendation? No more pregnancy, should not encourage further pregnancy. My
yes,
feeling
actually, I want to ask you, what do you think?
Oh, actually, Bianca has a lot more experience with this. I'm gonna ask Bianca to answer that one, and then Rasha can take over the further questions. I think it's always very, very difficult myself, and that it really should weigh up all the discussion with the patient and what the pros and cons are. But Bianca, perhaps you want to comment on that?
Yeah, sure. My personal perspective from a nephrologist is that she's a high-risk candidate.
Yeah.
My experience with working with women is that you can't decide for them. So you need to lay out the risks. What is her risk of progression to kidney disease with her following pregnancy? What is the risk to the baby? And is she willing to take that risk? And it's a very personal decision. And our job as nephrologists are to support our patients with whatever decision is made, which is incredibly tricky in some of our environments, like especially the one that we work in, where there's no guarantee to renal replacement therapy should your kidneys fail. So this is a very difficult and very real decision that a lot of the women in our service have to make. And I think our jobs as service providers is to provide people with the information that they need to make the best decision for themselves.
Yeah, I would echo
agree.
that. Yeah, excellent. Okay, so the next question I'm going to send, I know Rashi had a beautiful table on this, but I'm assuming this is about the soluble FLT1 versus placental growth factor ratio and its role. And you did touch on that, but perhaps you can just emphasize in the decision of IS.
Yes. Dr. Rash, will you answer?
He's going to find, I think you can find a slide, no? You don't have to.
So it's regarding the use of placental growth factor and SFLT ratio in differentiation between preeclampsia and kidney disease. I think those who are lucky to have the test, they actually do and rely on for differentiation and for the decision of immunosuppression. They do. We had the opportunity to do this test only for one case in maybe 1 month ago, and we found an evidence of severe placental ischemia. And based on this, we stopped an immunosuppression that we have actually started before we knew the result of the test. So yeah, so helpful, and it is recommended in the NICE guidelines and many I think organizational recommendations to do and to differentiate and to rely on as predictor of preeclampsia and differentiating this between preeclampsia and other kidney disease.
Excellent. Thanks, Rasha. Can I just remind everyone just to mute themselves? I'll just ask a couple of, I think we've got we've run over time, but I just want to ask a couple of other questions because I think they're important. One question was, I've missed the comparison. Sorry, Aman, I know you asked this, but about should we include pregnant ladies with lupus as well in the comparison? But I was uncertain which comparison she was referring to.
I think she referring to the differential diagnosis should be one of the differentials.
Oh, okay. Should we, yeah, okay. If it's a differential, perhaps that's where should we be including lupus nephritis as well in the comparison? Not quite sure I've asked the right question.
I think she means regarding the case.
I'm not sure. I don't think so. The question came up when you were doing your talk. So I wasn't sure whether, yeah. Iman, are you on the call still?
She's muted, she cannot talk.
Oh, okay, no problem. Well, that's not very nice. Okay, so I think what we'll do, we can maybe, I'll ask her and we'll report back to her because she's in my unit. So that is great. Is preeclampsia more common than IgA? What is the most common GN?
So I think a difficult question maybe to define in which glomerular disorder preeclampsia is more common in. But it depends upon the prevalence of these glomerular disorders in the presented studies or the population. Generally speaking, if IgA is one of the most frequent glomerular disorders and having reporting this disease in almost young and middle-aged women, we will have more cases of preeclampsia encountered on this, or at least primarily diagnosed as preeclampsia, because as we just said, there is difficult or challenging point to differentiate between both, between having CKD or between having glomerular disorder and having preeclampsia. So yeah, we have many cases of preeclampsia diagnosed in patients with underlying glomerular disease or with de novo glomerular disease during pregnancy, but to have a sharp delineation between both, yet still tricky.
Thanks, Rasha. I'm just going to quickly get through the last couple. I think it's important, and one was related to, given the preterm, long-term kidney disease related to gestational age or baby's weight, is delivering at 37 weeks considered safe?
It seems that, according to the available evidence, is that the process of nephrogenesis is almost mature by 37 weeks.
Yeah.
So having delivery after 37 weeks, maybe at 37 weeks, is a little bit better than having a preterm pregnancy before 37, and more and more better before 32 weeks. So it's like directly proportional to the degree of prematurity and the degree of gestational age at which termination of pregnancy was made.
Okay, I think we've probably done enough now, although I'd love to chat about this longer. But Prof, I think it's probably time to wrap up. We can send the chats to our speakers and ensure we get back to, send the chats to our speakers and ensure that they get back to all the participants. But I must say it's been a fabulous evening, and thank you everybody for their fabulous questions. They've actually been quite challenging. So I can see that everybody's quite involved in the presentation. So thank you everybody for participating in this webinar. I'm going to hand it back to Prof, who I think also wants to discuss the critical care fellowship that I see was also on the chat.
Thank you so much, Nikki, for this wonderful moderation of this session. Thank you, Dr. Rasha and Dr. Shuruk, for the nice presentation. This was a wonderful webinar today. I think we have learned a lot. And actually, what I have learned more is what knowledge we have is very limited. We need to know more and more. We need to study and investigate more and more. What we know is much less than what we ignore. Even as Dr. Bayanika mentioned in her presentation, the updates that has happened for several years in the KDIGO guidelines wasn't like a breakthrough. It was only few things that has been updated. So I think we need more and more studies, better progress and success in the field. But anyway, we are learning. This is a good news, a good part of it. We are still learning. I really appreciate everyone's contribution today. That's a great webinar. And our next webinar should be on May 30. I put the critical care nephrology links in the chat box if you are interested, or if you know anyone who might be interested, let us know. Today is again the deadline, so sorry, it's might be a little bit late, but they still have a chance. And I see that all of you guys have very good engagement and progress in the fellowship, so I'm very happy with that. And this week, there is no scientific materials released in the platform, but starting from Monday, you will have the amyloidosis educational materials and the MPGNs and the C3 glomerulopathy. Then this will be followed by the live webinar. With that said, I think that's enough for tonight, and I hope everyone can enjoy the rest of his evening or night. Thank you.
Thank you. Thank you so much.
Yeah.
Bye.